Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña.
Welcome back to EM Pulse. Today is a different sort of podcast because we are celebrating the end of an era in the UC Davis Emergency Department. Our department chair for 19 years, Dr. Nate Kuppermann, is moving on to greener pastures, or maybe just different pastures. Nate is going to be the Executive Vice President, Chief Academic Officer, and Chair of Pediatrics at Children's National Hospital in Washington, D.C.
This podcast is for all of you out there wanting to learn about the arc of an academic emergency department, and maybe you want to glean a few tips if you are considering being a department chair or an administrator.
So we are here, hopefully not for the last time, but definitely not for the first time, with UC Davis Department Chair, Dr. Nathan Kuppermann. Welcome back, Nate.
Great to be back with you guys.
Nate, when did you first know that you wanted to be a department chair?
Well, it's funny you should ask because I actually didn't want to become a department chair.
Trick question.
Trick question. I'll tell you in brief how it happened. When I arrived at UC Davis in 1995, by the way, 1 or 2 months apart from Cheryl Vance, we were the first 2 PDM-trained faculty members. We were actually in the Department of Internal Medicine, and we were just the Division of Emergency Medicine.
Crazy.
So we were surrounded by internists and adult-oriented doctors. And over the initial years, there was a great movement to become a department because many departments of emergency medicine were emerging across the country, and we were soon to follow. The division chief at the time, Dr. Bob Derlett, really spearheaded the effort for us to become a department. And as we eked our way towards departmenthood, Bob Derlett retired, and there was a search for the first department chair. And I was not interested. I was in my office, taking care of patients, teaching, doing research, very happy. And I knew there were department chair candidates coming through. I didn't see any of them. I wasn't asked to interview anybody. I was just doing my thing. And this went on for a while, and a good match wasn't found. And then the department came to me and said, "Hey, Kuppermann, you need to be like our department chair." And I said, "Well, I'm like happy doing my thing here in my office, taking care of patients and whatnot." But one thing led to another, and I told the people who were in charge of the search that I would consider it with one condition. I need to continue doing the things that I really love doing, which was taking care of patients, teaching and doing research. So I would need an infrastructure that would allow me to do that. And making a long story short, we negotiated, they gave me the infrastructure, and then I became the department chair.
So obviously things have changed a lot if you were starting in the context of internal medicine. Tell us a little bit more about what that department looked like when you started back then.
Wow, you guys would not recognize this place. It's those old buildings that are still standing that are due to be taken down any time. But the emergency department, which was a division of emergency medicine, was housed in an old section of the hospital. There was a small pediatric area, 6 beds and a resuscitation room, and 2 large adult areas, but they were very old appearing. The volume at the time, we saw about 50,000 patients per year at the time. And just to put that in context, now, 20 years later, we see 100,000 patients per year. The other thing that was quite striking is that our left without being treated patients, as you both know, these are patients who have come to our registration desk and leave before a provider sees them, was between 15 and 20%. It was horrible. And for the listeners out there, of course, that's bad for patient quality and is a big safety risk because these were some sick patients who just never made it back there because we were crowded back then and the hospital was crowded back then. That is one thing that has continued over time. The other thing that I would say was distinctly different, at the time, our staff, there were many internal medicine trained folks who had grandfathered and grandmothered into emergency medicine, and not that many fellowship trained emergency physicians. And now, as you know, the great majority of our faculty are fellowship trained and whatnot. So really, it was a combination of the facilities were old. We didn't have much expertise within emergency medicine that is beyond emergency medicine. And also our academics reflected that. We didn't have any grants. We didn't have any major research. And we had, I think, one fellowship. So those are the big changes from 20 years ago to now.
So talk to me a little bit more about that change in volume, because I feel like I've noticed it even in the 10 years I've been here. What do you think the factors are? Is it just population growth, or what else is affecting that? And then what kind of adjustments did we have to make to handle that?
That's a great question, Sarah, and it's a multi-pronged answer, I would say. First of all, there has been population growth, certainly in the Sacramento region. That accounts for some of it. A lot of it due to movement out of the Bay Area towards more affordable living areas. I also think that access to primary care has greatly diminished over time. So people, it's not that they're using us as primary care per se, but they're sick because they don't have access to primary care and they come to emergency care.
Nate, do you think the space also has something to do with that as well? Because you mentioned we started with a much smaller department in a smaller space.
Yeah, that's a good point. That is, as big as you build emergency departments, you will always fill them. We know that. However, the space was very limited for the volume that we were seeing. That certainly accounted for a fair amount of that left without being treated number. So although our numbers have gone up, but our space have gone up, and also our left without being treated rate has gone amazingly down over the last 20 years, despite the increase in patient volume.
If you build it, they will come.
If you build it, they will come. And what we've had to do over the last 20 years to accommodate that is a myriad of things. Ideally, what really empties an emergency department, as you both know, is you have hospital beds upstairs that sick patients could go up to, because we're not crowded with patients with colds. We'll see a patient with a cold, send them home. That's pretty quick and easy. We're really crowded with sick patients waiting for beds upstairs. So what we've had to do is that we've had to create a lot of new spaces and processes to help adjust for a very crowded house. And when I say house, I'm talking about the whole hospital. So we created Fast Track. We put a doc and triage. We do telehealth. We've added layers of physicians that come in at times when patients come in. We've adjusted in as many ways as we can. We created an observation space without creating an inpatient service ourselves to adjust for it. And it's actually worked to a certain degree. But as you both know, we still have our days where we are still unbelievably crowded, but always with patients who are waiting for inpatient beds.
Nate, I think you know better than most that a department isn't just defined, especially an academic department, by the patients that they see, by the clinical day-to-day, but by the people and by societal events that are happening and changes in healthcare. What are some of those like pinpoints, those like tack down moments where you're like, yeah, this is a pivotal moment in this arc of our department when you think back?
Yeah, there have been a handful of sentinel moments that I can remember that really marked a change in the way we provide care and in our emergency department. One, I will say, as someone who is a proponent of universal health care, we have had different eras in which we have and have not seen indigent patients. One of the problems in Sacramento is that there is no official county hospital. UC Davis, many, many years ago, was the county hospital, but it's been many years that we've not been. Nevertheless, we do a disproportionate share of indigent care, which we are all proud to do. And there have been times when that amount of indigent care that we're allowed to do for financial and other reasons has diminished over time. And that has usually been a source of contention because we as a group want to care for every patient that walks through our door, regardless of the ability to pay. So that's one thing that time marks when I remember that we were not able to kind of meet our mission in that way. Another important time mark, and I'm not doing this sort of sequentially, was certainly COVID. COVID arrived in 2019, and we won't go through the COVID story. I think we probably podcast about that before.
A little PTSD for everyone out there.
But, and by the way, I have 150 emails that I will compile into a book at some point as we were managing COVID in the department. But we certainly learned, amazing things about how to be efficient, how to be more sustainable, how to care for patients in a way that we decrease infection risk. We certainly learned a lot of things. So COVID was certainly a sentinel event. The murder of George Floyd, I think, was a sentinel event for everyone in this country but our department. That was in 2020. Before the murder of George Floyd, we already were a department that I think was very aware and cognizant and intentional around equity. But after the murder of George Floyd, I think the concept of equity skyrocketed in our department. We had, I think, just before or right at the same time, we had created our big DEI committee, which, as you know, consists of 5 different subcommittees: education, outreach, research, etc. We also thought we really need to change our mission statement to reflect our true values of delivering care with equity. So we have 5 bullet points on our mission statement. 4 of them were changed to embed some aspect of equity into the mission statement. And as an aside, now our DEI committee, besides all the great service we do, we actually do research in how and when we don't deliver inequitable care so that we can fix what we don't know. So that, I think, was an important event. I'm going to ratchet back a little bit in time. Another important event happened in 2010. That's when we went from our old, chaotic submarine of an emergency department to the modern emergency department in which we inhabit now. And I remember the day, it was 4 a.m. That's when you do a move like that because the census is low, and we made this kind of stealth move to the new emergency department. And it really did allow us to raise the bar on care because the physical environment is important in the delivery of care as well. So those are just some of the important moments that I can remember.
So looking back, what are some accomplishments that you feel most proud of or most impressed with in terms of the growth of our department?
Yeah, I'll break those down into, first and most important as always, is clinical. The delivery of clinical care, what we did 20 years ago, I think was really good. I think what we do now is outstanding. And that's for a number of reasons, some of which we've already talked about. Our facility is better. I think the training of our physicians are better. I mean, we have outstanding physicians who are not fellowship trained. But to be quite honest, over the last 10 years, we essentially have only hired fellowship trained physicians. And it's not because we're snooty. It's because fellowship trained physicians have an added expertise so that when we train our trainees, I want to make sure they are learning the state-of-the-art, most contemporary emergency care, because we're not only training clinicians, but we want to train leaders in our field. So that I'm very proud of. Our fellowships that we have went from 1 to 11, and they go from everything from research to addiction medicine to geriatric emergency medicine. I'm really proud of that. The other thing I am really proud of is that our emergency department, yes, we're really good at sepsis care and chest pain and fever in infants, but we take on some of the maladies of society that really lead to poor health, adverse outcomes, emergency department visits, but are somewhat opaque to the public. That includes substance use disorders. We have an incredible substance use disorder team. As you know, we have an addiction medicine fellowship. That's really super important. We have taken on sex trafficking in the ED. I think your very first podcast, as I recall, was about sex trafficking in the ED. I consider that like sepsis. That is, if you miss somebody who's been sex trafficked, they might come back dead the next time you see them. So these are things, again, that aren't what people talk about in emergency care, but we've embraced them as a department because we know it's an important part of societal ills that we feel responsible for. So on the clinical front, I'm really super proud of that. On the education front, as I mentioned, the fellowships I think are really foundational. Not only does it allow us to train leaders, but it helps the faculty stay on our game. We're training fellows, and
For sure.
and they make us stay sharp. Our residency has grown, profoundly. I think we had, when I started, 6 residents a year, now to 20, and I really love the merger of having residents from the Air Force working with civilian residents as well, and just our whole approach to teaching evidence-based care has been great. And the last thing I'll say, well, actually 2 last things I'll say. One about research. When this department started, we had no funded research. There were some publications and whatnot, but we as a group embraced network research, knowing that when you do research in networks, you can have impactful care. So we've gotten involved in PCARN, as we know, is the Pediatric Research Network, and SIREN, the Adult Emergency Medicine Network. And our NIH rankings just skyrocketed up, and we've been in the top 10 to 20 for the last 15 years for NIH funding. So I'm very proud of that. Also, with the notion that our goal is to create leaders in every realm. And the last thing I'll say is it's sort of going back to this issue where we talked about with regard to substance use and sex trafficking, because we're also aware that ultimately, perhaps the most important thing that's going to affect our health and the health of our children is climate. We've taken on sustainability. It's a big part of our department. We have sustainability issues regarding, waste reduction, reusable gowns. We've been going on sustainability work rounds for 15 years, looking for things that are wasteful that we should stop doing. And the way we've embraced telehealth is just another part of sustainability, because if you don't need to drive in for care, you can do it by telehealth. So I guess in sum, what I'm most proud of, I'm proud of all of these things. The clinical care always is most important because that's really, as physicians, what we are meant to do. But I like to think that our department has embraced all 4 legs of the stool, from clinical care, education, research, advocacy, and more, and we've taken them all to the highest level over the last 20 years.
That's very true, actually. As I look at, even the changes that we've seen in our time here, I see all of that growth, and it's really amazing. Not to say that it's all easy, right, Nate? What are just like an example of something that was challenging, and how did we overcome that as a department?
Well, first I'll tell you a funny story that was just personally challenging, and then I'll talk about a more serious, a department-oriented one. But I think I was chair for, a month or 2. And like I told you guys, I hadn't gone to chair school. I wasn't even interested in becoming a chair until I was dragged into this. But then I soon got to like it. But about 1 or 2 months into it, this is 20 years ago, so people are completely anonymized, but a chair from another program calls me and says, I think a faculty member at my place is having an affair with a faculty member at your place. What am I going to do about that? And I said, and I was thinking on the blurb on the side of my brain, am I supposed to do something about it? Is that, aren't people allowed to just live their lives? And, so I wonder, God, is this a chair thing? Anyway, so that was my first, my chair moment. And then that call just, ended and nothing ever happened to that. But actually, to be quite honest, I think one of, if not the most important challenge we've faced as a department, and also personally challenging because, of course, I have to lead the advocacy around this, is around boarding. And again, for the listeners, boarding is when you have sick patients. These are patients who are waiting for admissions to go upstairs, but there's no beds upstairs, so they board in your emergency department. And we have gotten very used to accommodating a certain number of boarded patients and still being able to deliver outstanding emergency care. But there's a threshold number beyond which things get unsafe. Very clear. We have had bad events happen when we are beyond a certain threshold. And the challenge is our hospital is, one house where we in the emergency department were sort of competing, shall we say, for beds with physicians who are doing elective surgeries and referral patients and all sorts of, they're all important, but we only have one house and it's very crowded. So the hardest discussions I've had is to emphasize we should not be allowed to reach that critical level of boarding where serious adverse events happen to our patients, and they have happened. So those discussions are really hard because a bed that we take means another bed that's not available. There's financial implications and whatnot. But at the end, we all have to stick to our principles of integrity and the Hippocratic Oath and at first do no harm. So advocating around boarding and what can we do when we hit that critical threshold has been the biggest challenge of my career and continues to be.
Yeah, and I think we all feel that. And we have actually done some episodes about that as well. And speaking of our podcast, you were one of the early champions of our podcast and also of our social media presence in general. So tell me about that, because that wasn't as big of a thing back when we started.
Yeah, actually, it's funny. I was talking about the two of you when we're brainstorming around social media, and I wanted to create a division of social media. I wasn't sure what to even call it back then, and why I knew this would be important is that, again, taking a holistic view around health of population, just like those programs that we as a department have taken on. If we really want to improve the health of the population, we need to deliver great care. That's most important. We need to educate our trainees really well, and we have to come up with cutting-edge, novel evidence that will improve the care populations. And all of these things, except for the immediate patient care, you need to get it out to the public. In the old days, we would get journals and read journals or the throwaway paper stuff, but we don't do that. And it was very clear to me. I have 3 children who were raised in the digital era, that social media was the way to reach the audience who we really cared to reach, who are going to be caring for patients, who are going to be listening to evidence and incorporating it into their practice. So I knew in all forms, I wasn't sure what form was going to be the most important, whether it was podcasting, which of course you guys have taken to like a new level, or was it going to be, blogging or tweeting, etc. But I knew that it was going to be important for it's not getting just the UC Davis message out. It's just for getting critical information to improve the health of populations out.
Well, I am certainly appreciative of that, Nate, that you recognize that early and just were like, okay, we need to be in this sphere. This is our mission. This is where we want to be and why we want to share with our community. You guys figure out how to make that happen, and I'll support you in that process. And I appreciate that innovation from the beginning. Now, to me, that seems like one of the really cool things about being a department chair. But Nate, tell us, what is one of the best parts about being a department chair?
Yeah, so I'll say after, joking about, but telling you the truth that I didn't seek this out. Having said that, within 6 months, I was already enjoying myself being a chair with the notion that it wasn't the only thing I was doing. I still had my research. I was still seeing patients, doing education because I love doing those things. Having said that, the 2 greatest parts of being a department chair, first, is just this. I just look at my relationship with the 2 of you. We're colleagues. We're good friends. You have the privilege as a department chair to getting to know people in a way that you wouldn't been able to get to know. And that, for me, is never lost. I consider that number one. The ability to connect with colleagues, help them achieve. Now, again, I'm going to give you guys an example. You guys have achieved what you've done on your own. My job was to blaze whatever trail that I could so that you could be your best you and achieve all the great things you do. And that's the privilege that a chair has. So that is the most important thing. The second thing is being able to create programs in your vision. It's always, of course, with big teams. And I've really prided myself in leading. I call it horizontal leadership. Horizontal leadership means that I will help generate ideas, I will help blaze the trails, and then I empower people to do these things. But having said that, these programs we talked about, they weren't my creations per se around substance use or trafficking or all these fellowships. They were done in partnership but they were part of my vision that others help me formulate and develop, and you get the ability to do that as a chair. And that is very powerful and very rewarding personally. Those, I would say, are the two biggest things being a chair.
That's huge.
Yeah. So Nate, with all this experience now, what advice do you have for someone who might want to become a chair?
So first of all, my advice for someone who wanted to be a chair, first I would just take one step higher and say, there are lots of ways to lead, and you don't have to be a chair to lead. People lead by leading programmatic efforts, by leading fellowships, leading residencies, doing a lot of things. I have researcher colleagues who've contemplated being a chair, but in fact, what's more appropriate for them is to run a research center. That's the most important thing. So the first thing I would say is make sure that this is the leadership role that you would like to have. For me, it's actually worked out really well for the reasons I mentioned. I really enjoy interacting with faculty and programmatic building. What I would say, however, is don't do it too early, because once you become a chair, there are a lot of administrative tasks that go along with it. So you're going to have to sacrifice some of the things that you may really enjoy doing. And these leadership positions, they come up all the time. So make sure you get all the things that you want out of your career before you become a chair. You'll still be able to continue some of them, but not at the same pace as you were doing before. So don't be in a rush. It really is a marathon, and you have lots of opportunities. The second thing I would say, really importantly, is keep your day job. That is, keep something else going. And for me, I've always liked taking care of patients, and I like to teach, but probably of the legs of the stool, a researcher at heart. So I continued my research probably as much as I did from before I was a chair, because I'm passionate about it, and it keeps the administrative part of being a chair, that part, tolerable. That is, because there's always unsavory parts of leadership, HR stuff, these complicated discussions that have to be had and whatnot. So keep something that you're really passionate about, very active. It could be education, it could be being a clinician, it could be a researcher, whatever it is, but don't give that up. And then the last thing I would say is that make sure that when the time comes and you're negotiating to be a chair, make sure that it's set up for you so that you can keep those important pieces alive and active. I greatly benefited, I have to say, by two people. I'll just call them out. The dean at the time when I became a chair was Joe Silva. And he was the chair of internal medicine before I became the dean. And he knew that I was passionate about all these things. And he sort of empowered me and gave me the resources to create, the vice chairs and the other pieces to allow me to continue my passions. And I have to mention Fred Myers as well early on, because there's two important commodities in all of our lives: money and time. It's true for everybody. The money thing, we try to pay as well we can in the department, but time is something that is like sacred. Fred Myers, who was the chair of internal medicine, when I arrived as a peds emergency physician, after a few years, he came to me and said, "Hey, Nate, you're doing a lot of research and you need more time to do it." So he gave me the time to do that. So back to this issue of being a chair is that when you become chair, you just have to make sure that you're given the gift of time so that you can continue to pursue your passion while you do your vision of being a chair.
Well, Nate, we celebrate the impact that you have had on our podcast, on our department, and probably most importantly, our community. We wish you the best in this next part of your journey.
Thank you both very much. Really appreciate it.